Hi, this is Maya Steinbrück, and this is going to be video one of the portfolio I'm doing on ACL tears. Today, we're just going to be talking about the signs, risks, and factors in female athletes that are associated with ACL tears and just kind of get a general overview of what ACL tears look like. Okay, so first of all, what is an ACL? The ACL is your anterior cruciate ligament. Its function is basically to prevent anterior tibial translation, and it also aids in some resisting of excessive extension or internal rotation. Tears are really common and they're very serious injuries. There's an estimated incidence of around 200,000 cases per year in just the US alone. Most of them are reported as being non-contact rather than contact injuries. And then 80% of cases had meniscal injuries and repairs associated with the ACL tear. So that means that something else is also being affected, and that was from a study done in 2019 from those authors. Okay, so just some things we're going to talk about today. First one's going to be indications of the tear, signs and symptoms. Second one's just going to be risk factors. We're going to do sports and movements that can be risk factors and also female-specific risk factors. The third one we're going to talk about is mechanisms of injury, how the ACL actually does tear. And then four, we're just going to go over surgery and rehabilitation, some basics of what that looks like. Okay, so first one, indications of ACL tears. So first, signs and symptoms. An ACL tear can be associated with a pop sound or a sensation at the time of injury. It's also associated with sudden severe pain, rapid swelling, instability, which is a feeling of your knee kind of giving out and not being stable, difficulty weight bearing, and also a limited range of motion, which can be due to that swelling. And then a diagnosis, one of the tests that you can do is a Lockman's test. So if you get a positive on that, and you also really do need a doctor diagnosis and an MRI scan to confirm. Usually an orthopedic surgeon will request an MRI when you go to see them. And then you can partially tear your ACL or full tear, or both of those are possible. And then you can see in this image that that would be a complete tear of the ACL. It sits right in that front compartment of the knee. Two are injury risk factors. We'll do some common factors and then really focus on the female specific factors. Okay, so some common risk factors, any movements that involve a quick change of direction, that includes cutting, jumping, or a jump to stop, or an uncontrolled hyperextension of the knee joint, which can occur during those movements. And then also increased joint laxity can occur for male and females, but it is more common in females. And then some common sports is soccer, basketball, football, skiing, and handball is actually shown to be one of the most common ACL tear sports. Okay, so some female-specific risk factors, hormonal changes during the pre-ovulatory phase of the menstrual cycle. Joints are more in that laxative state, so it's easier for things to get torn as that knee is moving through different sport movements. So that's just something to be aware of. And then less muscle mass. Usually that quad to hamstring strength ratio in women can be shown to be a little bit more unequal, which can cause when the quads are dominant and the hamstrings are less, we can see that imbalance, which can lead to ACL tears. Also, just having eccentric control, more muscle mass gives you more eccentric control, and also neuromuscular deficits is shown to also lead to ACL tears. And then a greater Q angle. This is the angle that comes from the hip to the knee. So we measure it from the ASIS, the anterior superior iliac crest, and then we go down to the tibial tuberosity. And when the patella, and then the line that intersects the patella straight down kind of shows us that angle when we measure it. And this can contribute in a practical setting to just awkward cutting mechanics and knee valgus if it's too far in. It is shown to be greater in females, so that could also be a potential risk factor. And then ACL size and orientation in relationship to the femoral notch. Some studies, there's been some conflicting research on this because some studies show that the ACL is smaller in women or the femoral notch isn't as deep, so it doesn't help the ACL like be as stable. So that can maybe be one, but it hasn't been really proved over and over again in research. So yeah, just wanted to note that one. Okay, and then statistics for specifically female ACL tears. So the incidence of female to male is 3.5 times greater in basketball and 2.8 times greater in soccer. And that was a study done in 2016. So we can see that in these two different sports, the ratio is from male to female is greater for females tearing their ACL. And then another systematic review talked about a re-tear rate, which is ranging from 6% to 31%. So after they tore their ACL the first time, they came back and then tore it again, that's 6 to 31%. And that could depend on, there's a couple of different graphs that we'll talk about later, and we'll get into more of the specifics of that. And then the same review says that an athlete between the ages of 10 and 25 years who returned to a pivoting or cutting sport after ACL reconstruction was 15 times more likely to sustain an ACL injury in the first 12 months than a previously uninjured athlete. So studies have shown, and orthopedic surgeons will also discuss this with you. If you have had an ACL tear, you're more likely to tear within that 12 months to 24-month period because the ACL still, while return to sport is shown to be okay at that time, the ACL can still be remodeling in a sense that your body's still taking that in as its own. And we just want to continue to build up that strength over time. So rehab doesn't stop right when you return to sport. We really want to focus on getting that re-tear rate down. So continuing rehabilitation is really important for that. Okay, and then mechanism of injury, this is going to be how the ACL is actually torn in those movements. So excessive knee valgus and a caving in of the knee. This can happen in cutting, and cutting is a really normal movement in sport. We can't ask athletes not to cut, but too much of that knee valgus can cause injury. So we really want to focus on biomechanically improving that after injury and pre-injury, possibly scanning that in athletes. And then the second one's going to be twisting, pivoting, and landing. Injury from this can be caused by that biomechanical and muscular deficit. So if that hyperextension, this can usually happen in those three movements. And then that third one is hyperextension. And this can really happen in those awkward landing and twisting and pivoting movements. So those awkward situations where biomechanically we're just not seeing enough eccentric muscle control. And then when in a total knee extension, the ACL becomes compressed in the front cavity of the knee and it becomes more vulnerable to injury and a tear during that. So that happens during hyperextension. And injury and tear always occurs outside of a natural limit of the joint. So when forces are putting stress on the ACL and it's greater than it can tolerate, that's when an ACL tear occurs. And then surgery and rehab. So after you tear your ACL, these are kind of the things that you can expect. Surgical options and treatment plans is what we'll talk about. Okay, so surgical repair is required if you fully tear your ACL. And a couple of different graft options. There's a quadriceps tendon graft, and it uses the patient's own quad tendon to reconstruct a new ACL. And this is what we call tissue to bone. So the tissue comes from that other side of the quadriceps, and then the bone comes from the teeny bitty top of the patella. And then a patellar tendon graft comes from that bottom patella tendon, and that is bone to bone because it comes from the bottom of the patella and then the tibia as well. And then a hamstring graft, which is tissue to tissue, but that comes from the posterior side of the leg from that hamstring tendon. And then a cadaver graft is also an option, and it uses an ACL from a deceased donor to replace the torn ACL, which is also bone to bone since they're taking that original ACL from a cadaver. And then there's some conflicting research about which one's the best. It shows that quad and patellar tendon grafts show more long-term results with little complications, where the other ones could be shown with a cadaver specifically. That graft can be shown to sometimes not take, depending on like whose tissue it is. That cadaver possibly could not be taken and could be rejected in the own body. And then a hamstring, since it's tissue to tissue, can be a thinner graft. And then just a fun little stat, 85 to 90% of ACL cases decide to get ACL reconstruction surgery. I would assume because that's mostly athletes. I would venture to guess that the rest of that 15 to 10% are maybe not athletes, older population, things like that. And then you can see this picture right here that kind of shows, this is just an example of what that ACL looks like. Goes through some tunnels in the tibia and the femur to reconstruct it. And then rehabilitation plans. So this starts from the time of injury and a diagnosis until return to sport. And continuation of a rehab into strength and conditioning plan to prevent re-injury is like what I mentioned earlier. We want to focus on it from that 12-month to 24-month period. And rehab usually takes 6 to 12 months just to return to sport. Physical therapy is so important. This is who will be doing your rehabilitation plan pre-surgery. The goal is really to restore a range of motion and reduce swelling and mitigate atrophy. Atrophy occurs very soon after ACL injury. And we also want to restore range of motion before surgery to prevent any deficits after surgery. And then post surgery, our goal is to restore complete function and progress to return to sport. So this is just an example of a protocol and plan. It's called the Moon Protocol. Doctors all have different protocols they follow, but most of them represent the same goals. And this is kind of taking from a couple different things. So phase one is going to be a partial weight bearing phase, and your brace is going to be 0 to 90 degrees. Usually you're locked in a brace. Some surgeons use them, some surgeons don't. And this is a 0 to 6 week period. And really our goals are controlling swelling, restoring range of motion, and getting that quad function back. Phase two is going to be full weight bearing and progressing to exercises like a single leg closed kinetic chain, so on the ground, TKEs, things like that. We want to get full range of motion back. This is going to be a 6 to 12 week period, and we're really progressing with weight and strength. And then phase three is heavy strengthening. We want to get limb symmetry so we can return to running and jumping, and that's that prep phase. And this is around 3 to 6 months. And then phase four is reconditioning for sports, correcting deficits that can still be seen by the physical therapist, and then return to sport testing and really focusing on plyometrics to get that return to sport speed and function back. So these are just a couple crucial pieces to ACL rehab. Usually your surgeon will have you start 48 to 72 hours after surgery. And their goal is really to restore that range of motion quickly, and total knee extension especially. Flexion kind of comes a little bit later. And this is just to prevent any scar tissue fibrosis forming in the joint. And then quadriceps function. Neurological damage occurs right after tissue damage, especially ACL. So we want to focus on quad sets, straight leg raises, E-stim if that neurological connection is not coming back on the patient's own, and then BFR for gaining strength and size back for the quad. And then psychological support also. Psychological support is so important by coaches and teammates and the physical therapist and surgeon themselves to help that athlete feel confident. We'll talk about that in a later video. And there's also more that we'll also talk about throughout these next 5 videos. These are just some references that I use, the research articles that I talked about. So yeah, thank you.